and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Today's episode highlights one of the sessions being held at the ACR Convergence Meeting 2025. The session we will discuss today is titled When Cancer Immunotherapy Triggers Autoimmunity, the Rheumatologist's Role in Immune Checkpoint Inhibitor Toxicity. A link to the session and disclosures can be found in our show notes from today. I'm so happy to be joined today by Dr. Elad Sharon to discuss this session. Dr. Sharon is a medical oncologist at the Dana-Farber Cancer Institute and Harvard Medical School. He received his MD from Baylor College of Medicine in Houston, Texas in 2003 and completed his internal medicine residency at Emory University in 2006. He obtained a Master's of Public Health degree at the Harvard School of Public Health in 2009 and subsequently completed Hematology-Oncology Fellowship at the NIH in 2011. With a background in both oncology and public health, Dr. Sharon has been a leading voice in the study of immune-related adverse events associated with cancer immunotherapy. Before joining Dana-Farber, he served as a senior investigator at the National Cancer Institute, where he helped to shape the national research strategy around immune checkpoint inhibitors and their toxicities. Dr. Sharon's work bridges the fields of oncology, immunology, and rheumatology, focusing on how cancer therapies can trigger autoimmune-like responses. He is particularly interested in the mechanisms underlying rheumatologic immune-related adverse events and the critical role of multidisciplinary care in managing these complex patients. His research and clinical leadership continue to inform the best practices for balancing effective cancer treatment with immune safety. Welcome to the show, Elad.
Thanks so much. That's quite an introduction. I really appreciate it and honored to be on your show.
Well, so I wanted to start with a little bit of background about immune checkpoint inhibitors. They've really revolutionized oncology treatment. Can you briefly explain how they work and why they inadvertently trigger autoimmune-like toxicity?
Absolutely. So these agents are essentially causing the equivalent of a deficiency in immune regulation. So there are certain immune checkpoints that are what I would call multiply redundant mechanisms that prevent excess inflammation or excess activity from the immune system. We have come to call those immune checkpoints. CTLA-4 was the first one that actually led to approval in the clinic. That is an antagonist in oncology that was first approved in the form of ipilimumab in 2011. But it's important to note that the agonist for CTLA-4 was actually approved in rheumatology in 2003 or around there. I know that the New England Journal article for abatacept, which is a CTLA-4 agonist, was approved or was at least published in 2003. The other main immune checkpoint inhibitor that is approved and used currently in oncology and much more widely used than the CTLA-4 inhibitor are multiple PD-1 and PD-L1 inhibitors that affect that axis. The axis is known as programmed cell death 1 or programmed cell death ligand 1. That's the receptor ligand interaction that has to be blocked in order for this particular form of immune checkpoint blockade to occur. And again, PD-1 agonists are actually being studied specifically in rheumatology. What these drugs do in oncology is make it so that T cells that otherwise have the likelihood of trending towards inactivity are blocked from having that particular attempt to essentially tone themselves down. And so the default pathway that exists is essentially greater activity. Correspondingly, as you know, is probably obvious to the rheumatologist and immunologist who might be listening, that means that this fairly blunt instrument pushes the body towards more of an autoimmune phenotype or the immune system to more of an autoimmune posture. So from the perspective of cancer, that could potentially be beneficial. But from the perspective of immune-related adverse events, this can essentially trigger the immune system to attack the body in other areas. These multiply redundant mechanisms that exist are therefore really critical in maintaining an immune homeostasis that is perturbed by the use of these agents. So the main ones, again, being CTLA4, PD1 slash PDL1, and then there's a third immune checkpoint blocker that affects LAG3, which was more recently approved and is currently in use only in melanoma.
Fabulous, fabulous introduction. So, how common is it if you're receiving one of these therapies to experience an immune related adverse event?
It does vary to some degree by the other agents that are potentially used in a particular disease. So I would argue that chemotherapy, in particular, as an example, probably attenuates a little bit of the immune response. Obviously, it's used in rheumatology as an example, but in other diseases as well. And so the use of chemotherapy with immuno-oncology agents probably leads to some lower levels of immune activation and therefore also lower levels of immune related adverse events, where we have many approvals at this point for the combination of CTLA4 and PD1, or sometimes PDL1 with CTLA4 in the form of durvalumab and tremelimumab. Those are PDL1 and CTLA4 antagonists, respectively, that are available from AstraZeneca. Those combinations of two IO agents, two immuno-oncology agents, can actually be much more likely to lead to immune-related adverse events, which are also more severe. Those events, when they occur, can affect up to 60% or even sometimes higher rates of individuals who receive both agents at high enough doses. And those individuals also oftentimes suffer from, again, more severe side effects, but also potentially have a greater benefit in terms of response to these immune-based therapies. And so that yin and yang is sort of goes together, and that's what we have to deal with in immuno-oncology drug development, that there's inherently some degree of immuno-oncology adverse event management that's kind of built into the equation.
Yeah, I think it's really important to remember. So, of these immune related adverse events, what are the most common rheumatologic manifestations that you see? And how do these drug induced reactions differ from classic autoimmune diseases?
Very interesting. So I see quite a few cases of inflammatory arthritis. It's likely underreported, but also a great deal of phenotype that is akin to polymyalgia rheumatica. So PMR like side effects are extraordinarily common, at least in my experience. I think they're also underreported, that they're occurring in patients that are younger than sporadic or spontaneous PMR, as an example. Pretty much I think everyone is at equal risk. In particular, if they happen to be individuals who've suffered from PMR in the past, I've certainly seen those individuals have reactivation of PMR. So that's a major difference. And there are also PMR like symptoms, even for those patients that have other inflammatory arthritis. And so other kinds of therapies sometimes are necessary to treat those individuals other than low dose steroids and on occasion. Those are the main manifestations, something akin to rheumatoid arthritis. They're sort of a rare side effects that might be present for some patients. Perhaps a gout or a pseudo gout has certainly been reported, but inflammatory arthritis or ICI induced inflammatory arthritis that can affect some small joints or polymyalgia rheumatica are the most common. Less commonly, we do see cases of myositis that can manifest themselves, again, induced by the ICI therapy and also sometimes occurring or co occurring with a myocarditis and reportedly also myasthenia gravis. So, those syndromes, which are considerably rarer, are of great concern and can sometimes be associated with very severe and poor outcomes.
Yeah, no, it's a really helpful tip. And what do we know? And I guess since you bring up this kind of reactivation of a previously occurring PMR, what do we know about the mechanistic pathway and the overlap between the immune checkpoint induced autoimmunity and spontaneous autoimmune diseases?
It's a great question. I think, the simple answer and the one I actually truly believe is that we don't know enough. We do have a clinical trial, which I'm helping co-lead nationally. I began when I was initially at the NCI. That's called the AIM-NIVO trial. This is in coordination with my other national co-principal investigators, Hussein Taubi over at MD Anderson and Kathy Dumbrava, who's also at MD Anderson. So we have been working together along with researchers from around the country, for instance, over at Johns Hopkins, Laura Capelli and Bing Bingham, some dermatomyositis and systemic sclerosis researchers from Stanford, like Tomiko Katsumuda and David Fiorentino, Lorinda Chung. So several individuals who helped co-write these sections on, in some cases, like I said, systemic sclerosis and dermatomyositis. There's also Amy Shah, Noha Hassan Abdel Wahab, who just recently moved to Cleveland Clinic. So many, many investigators in the rheumatology field who've really helped work closely with us on this protocol. And one of the early concerns that we had was around inducing not just PMR, but also giant cell arteritis in these individuals that had PMR. I have to admit, I've diagnosed a lot of PMR. I have not yet seen myself any cases of giant cell arteritis, and I suspect that it's much less common in those patients that have ICI PMR. Even individuals who had headaches, reportedly along with something of a syndrome, ended up having negative temporal artery ultrasounds that we urgently and dramatically tried to obtain and then found them to be completely negative. And so there was just, a sporadic connection between, random headaches and what they had as PMR. So I suspect that the phenotype is slightly different, that these individuals are oftentimes just being affected by either proximal muscle weakness in sometimes the thighs, sometimes the shoulders, and sometimes both, but very, very rarely, and again, I have not personally seen it, giant cell arteritis. And that may be an actual difference in terms of how these diseases manifest themselves. And we do need to collect more data to determine what's happening. I think one of the things that makes it somewhat difficult to understand better what is happening for those patients that have an inflammatory arthritis caused or induced by immune checkpoint inhibitors is actually patient reporting is extremely poor. Individuals who are receiving these agents oftentimes are afraid to report to their physicians that they're experiencing at least low-grade side effects or things that they feel that they can manage themselves at home because they don't want to be taken off of the therapy, or they would like rather to focus on some of the other aspects of their care. And as a result, I found myself receiving these patients in consultation when, for instance, they have an ICI-induced hepatitis or an ICI-induced colitis. And when I ask the review of systems, that's when I discover that they've been suffering from an inflammatory arthritis of some kind for, sometimes many months prior to coming to my attention. And so that's a referral issue that unfortunately is partially actually potentially the fault of the oncologist. I don't want to absolve my specialty of not encouraging patients to, report their symptoms, but also I've definitely seen it that it's patients themselves that are actually underreporting their own symptoms because they simply are afraid of being placed on some sort of immunosuppressant and hoping that they would get a continued benefit from the immune checkpoint inhibitor if they're experiencing one.
So, with that in mind, and this challenge kind of recognizing these complications, are there any emerging biomarkers or patient characteristics that can help you predict who is likely to get them and who is at higher risk for these adverse events?
It's a great question. Certainly, we are looking at some of these biomarkers that actually are already known and happen to exist. I probably forgot to mention, and again, I think this is something we need to explore a little bit more closely. But these cases of ICI induced PMR seem to oftentimes actually have an elevation in ESR and
Mhm.
CRP, but sometimes they don't. And I know that the frequency of normal ESR and CRP for individuals with sporadic PMR is about 20%, or at least that's what's been quoted to me. I think it might be slightly higher in those individuals that have ICI induced PMR, but they also do have elevations in CRP and ESR. There are other probably markers of cytokines. We've seen IL-6 elevations at times. And, if you run a cytokine 13 or whatever panel you happen to have access to at your given institution, you'll see a number of different cytokines that can be elevated. But this is an area for ongoing research, and I think we need to determine what else might be out there that might predispose those individuals. I think that there's a lot of active and legitimate interest in looking at some of the autoantibodies that exist in some more common arthritides that may be elevated even at baseline and predispose some of these patients to receiving or ending up with an ICI-induced toxicity. I think I forgot to mention one that's actually quite important. Sjogren's syndrome is also relatively common, relatively underreported, and may actually have some, obviously, antibodies associated with it that are present that we should probably be looking for somewhat more frequently. And I've worked with some individuals like Warner, who's one of the national experts at the NIH, and putting or trying to put some of those patients on the AIM-NIVO trial so we can learn more about them. And in addition, Nicole LaBeouf, who's one of my colleagues at Brigham, a dermatologist, has been really instrumental in looking at new therapies for psoriasis. The more I think about it, there's so much more that the rheumatologist actually, covers. And so I should have mentioned, I apologize, Sjogren's and psoriasis in the same breath with the inflammatory arthritis and the PMR.
That's great. Don't apologize because it gives me a chance to ask you a follow-up question, which is, do you see these adverse events kind of being additive? So the longer someone remains on these checkpoint inhibitors, they get additional organ involvement or additional manifestations?
It's a great question. I don't know the answer to that. I probably have a little bit of a referral bias that I receive. And so it's a little bit hard for me to say specifically with regard to rheumatologic syndromes. I can say that there are a number of patients with other immune related adverse events that sometimes occur many months after they've completed therapy, even with immune checkpoint inhibitors, and particularly with regard to PD-1 therapies. CTLA4, probably this is true as well, but PD-1 or PD-L1 therapies are typically maintained for longer periods of time. And so as a result, we actually have a number of patients who present with all sorts of symptoms, including PMR, including inflammatory arthritis, but also other things like sometimes hepatitis or colitis or what have you, that can occur months after they've completed therapy or halted therapy for some other reason, like progression of their cancer. And so they're trying something else. Or simply they completed, for instance, use of an immune checkpoint inhibitor regimen in the adjuvant setting following surgery with a defined length of time that they're typically treated. And part of that is because of the very long half-life of these antibody-based therapeutics. Another part of it is because of the high avidity for the receptor. So we say that the drugs in themselves actually have a very high level of receptor occupancy. And so the receptor occupancy and the half-life of the drugs, both of those are so, I guess, avid slash long, respectively, that we can see patients that actually present some months following completion of therapy. It's important to note that initially, and just as an example, pembrolizumab was actually approved in a milligram per kilogram dose strategy, which later was transitioned to a flat dose. And the 2 milligram per kilogram dose was what was chosen in 2014 when pembrolizumab, which was the first PD-1 slash PD-L1 inhibitor that was approved, 2 milligrams per kilogram every 3 weeks was actually chosen. However, in the phase 1 trials, they had actually gone as high as 10 milligrams per kilogram every 2 weeks, which basically means that, and I'm not a pharmacokineticist, but I've been told that about a 7 times rate of higher exposure. And the truth is, Merck basically decided to go with a lower dose because they saw no difference in either efficacy or adverse events between the two dose levels, between the highest dose and the lowest dose. That essentially these drugs, the PD-1 and PD-L1 agents, have an extraordinarily wide therapeutic index. That's not true for CTLA-4. CTLA-4 actually has a dose-dependent effect, both for efficacy likely, although we typically can't seem to tolerate very high doses because the toxicity is certainly dose affected, that there's a dose response or dose toxicity relationship that we're familiar with in much of the rest of medicine. But PD-1 agents and PD-L1 agents seem to have an extremely wide therapeutic index. And so I think that actually contributes to sometimes some of the late effects. And actually, the real reason why I got on this tangent, so I apologize, but the real reason why I got on this long tangent about, in response to your question, is that I don't know, and I don't think anyone really knows, why we get some toxicities so late or so early. I don't think we have a good handle on why some patients are having these, manifestations of immune related adverse events, sometimes within days of being treated, and sometimes almost a year after getting treated with these agents. And I can't explain, I mean, I have my theories, obviously, in some cases, but I can't explain, especially the late effects, why they're occurring at all.
Yeah, so interesting. And I guess as a clinician, you also face a dilemma when someone develops one of these complications. Do you keep the medication going and add an immunosuppressant? Do you stop these potentially life saving cancer therapies? How do you approach these decisions and the ethical tensions that you are dealing with?
It can get a little complicated. Unfortunately, I would say that we're not usually dealing with a curative situation in many cases. And also, in many cases, while some of these drugs are the most effective agents that might have been looked at in a particular cancer of late, still, in most cases, only a minority of patients are actually showing a significant benefit. So that's always important to keep in mind because the benefit sometimes is uncertain, but the harm is usually somewhat clear. And so, one thing I sort of try to impress upon my oncology colleagues is those long half lives that we're talking about and that high degree of receptor avidity or receptor occupancy rate make it so that simply stopping the therapy is usually not changing anything for an individual, right? They're getting treated and we're flooding their system, we're flooding the receptors with an anti PD-1 antibody. And so, if we're doing all that, if we're flooding the system with an anti PD-1 antibody, and they're getting it presumably every 3 weeks or 4 weeks, depending on the regimen and the drug and what have you, those antibodies are still present in their system. And if they're still present in their system, there's not much that you're really doing by way of harm or benefit to a patient if you just simply stop therapy. You can
Mhm.
wait to determine more of what's happening most of the time without much harm to the patient's cancer, especially if you need to, run a few more diagnostic tests, maybe get a biopsy, run some blood work, see what's happening, or if you can wait, if there's a reason to wait, if the patient can tolerate it and there's no reason to add anything else. The real question is whether or not, as you state, you add some sort of immunosuppressant, and that is likely the only way that you're actually reversing one of these manifestations of an immune related adverse event. When possible, my goal obviously is to get actual tissue, get actual imaging, get the information that we need in order to affirm that this is what's happening and make sure also that we've excluded alternative potential explanations or causes, which perhaps are less of a concern for certain rheumatologic adverse events. Maybe it's a little bit clearer, but there are some things like pneumonitis that can potentially occur, as just an example. And there are so many things that can cause manifestations of interstitial lung disease or ground glass opacities or things that could affect your respiratory function that are not ICI induced pneumonitis. And I like to point out, just as an example, we have a therapy that is now routinely offered to those patients with stage 3 lung cancer, durvalumab, a PD-L1, that was approved after what was called the Pacific trial conducted by the AstraZeneca group in patients with non-small cell lung cancer, stage 3. So these patients, 3B, these patients get a regimen of chemoradiation, and following the chemoradiation, they get durvalumab. Those patients have a 34% rate of what they call pneumonitis. On the control arm, they had a 25% rate of pneumonitis, which essentially means that even if you're treating patients with what is now the standard of care of durvalumab and you're seeing the pneumonitis, a majority of the pneumonitis you're seeing probably would have occurred anyway as a result of the chemoradiation. And that's important to get the diagnosis right.
So, do patients who develop immune related adverse events actually end up having better cancer outcomes? And does that give you any understanding of the links between autoimmunity and anti tumor immunity?
So I think I can more easily address the first part of the question. And that is something obviously under investigation, but we do have hints as to whether or not there's an association. So one problem with answering a question like that is, if patients have more immune-related adverse events, do they have better outcomes? So there are individuals essentially that when they receive immune checkpoint inhibitors, if they live longer, they are prone to report more adverse events over time simply because they lived longer. And that biases some of these analyses that occur. So we took one of the trials that we conducted under the auspices, under the sponsorship of the National Cancer Institute in conjunction with BMS that provided us with nivolumab and ipilimumab, our PD-1 and CTLA-4 agents under contract. And we were able essentially to look at a landmark analysis. So we looked at the patients who were treated in the first cycle. And that trial, which involved 53 cohorts of patients with rare tumors, but all receiving the exact same therapy, we looked at those individuals who were treated under the trial regimen with the benefit of being able to grade the adverse events. We could see that individuals that had lower grade events did better than those individuals that had no immune-related adverse events in that first cycle versus those who had had higher grade or worse immune-related adverse events in that first cycle. Those individuals did worse. And we suspect that part of the reason why the individuals with higher grade immune-related adverse events did worse is because they received some degree of immunosuppression in order to treat their immune-related adverse events, and perhaps also that they halted the therapy, which does occur when you have a higher grade immune-related adverse event and likely does not occur when you have a lower grade immune-related adverse event.
I have to ask a follow up question because I don't think I've ever heard of a study that has 53 cohorts of patients. Tell us more about this interesting design and how on earth did you execute this study?
Well, it is to some degree a tribute to the investigators, Sandi Patel over at UCSD. He was under the mentorship of Rizal Kurzrock, who at the time was also at UCSD, University of California, San Diego. And the proposal essentially was to look at these individuals who had rare cancers, who were at the time not necessarily benefiting from the ability to receive therapy with immune checkpoint inhibitors, simply because of the fact that pharma was probably less interested in actually conducting trials with those patients with very rare tumors. And certainly, even if they saw some benefit in orphan drug designation or, what have you for an individual tumor, they certainly couldn't do very many of them. But there are many rare cancers out there. And so since we had a therapy that was broadly effective across many different kinds of cancers, we had reason to believe that there would be some potential benefit across a number of different cancers. And we wanted to test it in a manner that was consistent with good clinical trial practices and to formally evaluate to determine if there was, potentially a benefit for those individual cancers. Everyone received essentially the same therapy. And ultimately, there were hundreds of patients treated across up to 1,000 sites that were open across the United States and Canada and I believe some sites around the world. Regardless, those patients who were enrolled in the trial had a number of different cancers. All those cancers essentially collectively counted for our purposes for the purpose of essentially looking at the immune-related adverse events as almost like a pan-cancer trial.
Yeah, it's amazing that you did that, and I really give kudos to those investigators for thinking of that design and being able to get the job done. Astonishing. So I wanted to ask a little bit more about the long-term trajectory of these irAEs. You mentioned that sometimes they can occur late after even a drug has been discontinued. Once they happen, do they resolve? Do they persist and evolve into a chronic autoimmune condition? What happens to these patients?
I would say that most patients actually have resolution of the immune-related adverse event. So for the most part, particularly non-rheumatologic events, but even rheumatologic events, I'd say that the overwhelming majority, if treated appropriately, will have resolution. There are certain adverse events that are sometimes more challenging to treat, more difficult. I'd say pneumonitis might be among those where I think that the tools that we have that are available to us are probably inadequate, and we need to come up with better answers for those individuals who are suffering. But most of the adverse events that we're dealing with, if they're properly managed by individuals that are experienced and have the knowledge and up with the literature, so to speak, I think we do end up with good outcomes for those individuals. And usually these things can be resolved relatively quickly. I think sometimes we have individuals who are too eager to end immunosuppression for their patients. And so we do end up with some individuals, unfortunately, who are treated, for instance, for a PMR-like syndrome with a rather short course of steroids. And obviously, for those individuals, a recurrence can occur and not unexpectedly, because that would probably be true with sporadic PMR as well. And they can potentially, if again mismanaged, could end up seeming like they have a more chronic condition, but really it's that they didn't necessarily get the treatment that was needed for them. Now, that, of course, is an exception. There are individuals that have endocrine related, immune related adverse events, which are not really the topic, I guess, of this podcast or this conference, but endocrine tend to be permanent when they occur. If somebody gets a thyroiditis or a new onset diabetes or an adrenal insufficiency, those things we don't really treat with high dose steroids to suppress the immune system or some sort of response. Instead, those are certainly chronic and probably due to destruction of the organ in question.
So that's really helpful to know. I'm kind of fascinated with your role. Looking ahead, what research and clinical innovations do you think are most needed to improve the management of these irAEs and really support collaboration between oncologists and rheumatologists over the long term?
Oh, absolutely. That's, I think, critical if we're going to make progress really in the field. We obviously are inducing these problems, we're causing the adverse events. And the tools that are actually being developed, particularly in rheumatology, are essential and they can really change the outcome for these individuals. What our long term goal, obviously, is to separate anti tumor from anti host immunity. That's similar in a sense to what we've been trying to do in the bone marrow transplant field or hematopoietic stem cell transplant field in oncology for many years. That we are trying to make it so that, in that case, usually they call it a graft versus leukemia effect is enhanced, and a graft versus host effect, obviously, is diminished. And finding that special sauce, whether it be focusing on IL-17, IL-23, IL-6, what have you, all of these different adverse events could easily be better managed than what we are currently doing. Certainly, what I would argue is an over reliance on steroids. And we need to, just as a field in oncology, get over that to some degree and use more frequently all these different tools, at least when we're able to see, meaning when insurance or, cost issues are not a factor, to get these therapies in the veins or the mouths of patients, as the case may be, or subcutaneously as quickly as possible so that outcomes can be better, and hopefully outcomes not only for the cancer, but obviously for the adverse events can be minimized. And if the patient is not expected to get treated with the immune checkpoint inhibitor again, at least they can go on to their next therapy or go on to clinical trials or so forth. I think what we probably need most are more clinical trials for these individuals. We need the practitioners, clinical trialists in rheumatology to work with us so that we can find new therapies faster and that we can use the new tools that we have in rheumatology on those patients with cancer much faster and to the benefit of all.
And every rheumatologist listening to this podcast is happy that you want to reduce the steroid exposure. We completely agree with you. I like to ask our guests a few questions about their career and get to know the scientist behind the science. And so I'm going to switch direction now and ask you what originally drew you to oncology? And are you sure you weren't actually meant to be a rheumatologist?
That's a great question. Uh, and now I might think I maybe should be a rheumatologist. That's a
It's
fair
never too
point.
late.
Yeah, it's never too late. Can get a fellowship now. And I do, work with some of the rheumatology fellows. We actually had an irAE fellow last year who was coming to my clinic once a week, who was obviously helping us from the rheumatology group that Jeff Sparks over at Brigham Rheumatology, runs. So for me, cancer unfortunately affected my family. My mother passed away while I was in medical school, passed away around the time of the September 11th attacks, actually. There was obviously this great deal of national grief that was going on, and understandably so. And around that time, I also had this kind of lonely, scenario where I was dealing with obviously our private family grief as well. And at the time, initially, I got pushed away, I think, from oncology. Initially, I almost wanted to do something that was the further away from direct patient care. At least I perceived it to be so. Specifically, I was considering radiology. And as time went on, when I was doing the match, I ended up changing my mind and, essentially applying to internal medicine with the goal of going into oncology because I felt really compelled to advance research efforts for patients with cancer, which was almost a demand that my mother had of me when she was sick. Obviously, I had, personal reasons why I felt like I had to go into oncology, but I immediately upon arriving at the NIH where I was doing my fellowship, I saw some of the work that was being done by Steve Rosenberg over at the National Cancer Institute in the intramural program. He had been working with the immune system for many years, trying to look to see what method by which any manipulation could change the posture of the body towards a cancer and lead to its eradication. Steve Rosenberg was obviously involved with a lot of cell therapy, but also had worked in the area of IL-2 back in the 1980s and tumor infiltrating lymphocytes, which actually, even though he had been working on it for some years, only got approved actually in melanoma this past year. Now, a therapy available from a company called Iovance, but that was work that he was doing for a couple of decades before. So I sort of thought that, well, Dr. Rosenberg is going to figure all this out. We're going to have a cure for cancer fairly soon. And I decided to, you know, get interested in public health and I did that MPH, I think that you mentioned before. So unfortunately, I sort of realized that cell therapy, although it's really exciting, was not yet ready for the masses and for the mass market. And it's still somewhat challenging to see that through, although they're making more and more successes here and there. But as immune checkpoint inhibitors came onto the scene, I saw that there was actually an opportunity to utilize these therapies in a much broader manner. And that's probably fairly early on because we at the NCI, when I was, working as a medical officer over there and overseeing our clinical trials, work not only as the chief development or drug developer for the government for the National Cancer Institute sponsored trials, but also we work as the medical monitor, as it were, so that you're sort of in this position where you see all the benefit and all the harm of the therapies that you're involved with, or at least you have the potential to see all the benefit when we certainly see a lot of harm. And so that confluence of the benefit and the harm, the yin and the yang, the good and the bad sort of is what led me to this field of immune-related adverse events and to many of the wonderful collaborations I'm fortunate to have with some of the best rheumatologists, at least that I've encountered for the years. I'm sure there are quite a few. It's a wonderful field.
All rheumatologists are great. Just remember that. I'm kind of
Sure.
fascinated by that role you had at the National Cancer Institute. I wondered if you could tell us a little bit more. You really oversaw the NCI's cancer therapy evaluation program. You worked with academics, industry partners, and really helped develop these promising cancer therapies. We don't have anything similar to this for autoimmune disease or rheumatology. And so tell us more about that role. How did it come to be? And what did you learn from doing that position?
Certainly, yeah. I was overseeing many of the clinical trials. Obviously, I wasn't overseeing the whole program in the sense that CTEP, or the Cancer Therapy Evaluation Program, has been around for several decades. It was put together early on, and many of the groups that we might be familiar with or you might be familiar with in oncology are academic consortia that are funded by that program of mine that I was at when I was at the NCI. The program's called CTEP. It's referred to as that. It's had a very bland name. Cancer Therapy Evaluation Program could mean anything, I guess. But it's the program that funds organizations like the Alliance, of which I'm a member. I'm also a member of SWOG, which used to stand for Southwest Oncology Group. Now it's, I think, just SWOG, similar to the way that Kentucky Fried Chicken goes by KFC, and you don't hear hear KFC anymore. But ECOG, which was the Eastern Cooperative Oncology Group, which became famous because they have this performance status that became widely used, the Alliance, and then NRG and the Children's Oncology Group. These are all the big national groups that are funded by that organization that I'm a part of, was a part of rather, for many years. And there are also some phase one consortia that are funded at major academic centers around the country. Some of the power, though, of some of the national groups like ECOG and SWOG and the Alliance and so forth, is that they actually unite academic and community oncology organizations in one structure to run sometimes small but oftentimes large clinical trials, sometimes single arm, but hopefully more often randomized with some significant control to help advance the field. And one of the organizations, obviously, that's done the best is really the Children's Oncology Group. But it was present essentially and able to conduct its work because of the support that was provided by the US government over the many decades that this organization has existed.
Incredible that somebody had the foresight to build that structure and that it has been so successful across the many, many different types of cancer. So thank you for sharing with us that story. What pulled you back to academics? And do you have any tips for other people who want to follow a similar career path?
I don't know if I would recommend it. Um, Not the academics part. I like academics, but I don't know if I would suggest working for the government for 16 years before going into academics. I feel like I'm right now potentially defined as early career faculty, even though I've been in oncology for, a couple decades here now, or almost a couple decades, I guess, at the start of my fellowship. But I was fortunate, in a sense, shielded from some of the needs that you have when you're developing your career, in the sense that I didn't have to apply for grants. I was already working on a high level with major companies and biotech organizations and some national policy organizations as well at the start of the work that I was doing, under guidance, obviously, from some more experienced colleagues and with tremendous support from the organization. But the negative, I guess, the reason why I state as a potentially not necessarily the best path is that what that means for me is that now, having gone now to academics from the NIH, I don't have quite as much experience in some of the things that we actually do need. For instance, the grant writing and, the focus obviously on building, a narrow area of focus that only gradually expands as you move forward. I'm somewhat wide-eyed and, interested in a lot of different areas. So I'm lucky that my colleagues at Dana-Farber are tolerating that on me so far. I'm not sure how long that'll last if they get tired of me butting in and suggesting things in a variety of different areas. Again, usually that's something that, you develop over time. I thought academics looked like a lot of fun. I certainly think that there's a lot of, inherent curiosity and beauty in that, the inquiry that exists in academics. And that's something that I did definitely appreciated. At some point, I definitely saw that more direct involvement in running the clinical trials, myself as a principal investigator was something I was interested in doing. And I was only able to do it to a very limited extent when I was at the NCI because of the responsibilities really that I had in overseeing our network run trials and our sponsored efforts.
Yeah, no, I'm sure you bring more in your skills and experience than you're giving yourself credit for there. So I certain that this career path you followed was a very good one for you, and don't ever hesitate about that.
Kind of you just say, well, I guess that's the story you have to look at the end and figure out.
So thank you so much for joining us today and for sharing all of this amazing work. We're really looking forward to your session at the ACR Convergence meeting.
Thank you so much. It really, again, an honor to be on the podcast.